Free audio post-production by alphonic.com.
Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And on our podcast this year, we are introducing a new series that we're calling Heart to Heart. In this series, we'll be speaking with patients and the healthcare providers who treat them. Our hope is that you'll be encouraged and empowered by their stories, whether you are a survivor, a healthcare provider, or a supportive family member or friend. So thanks for joining us on this episode of Heart to Heart. And today I'm joined by two friends and colleagues of ICOS, along with our patient advocate, who I'll introduce in just a moment. But first, I want to welcome the ICOS president, Dr. Susan Dent, who is a medical oncologist, especially in breast cancer at the University of Rochester in New York. Welcome, Susan.
Thank you. Welcome.
And we're also joined by the physician who's actually been providing the care for our guest today for some time, Dr. Anna Barac, who's a medical director of the Cardio-Oncology program at Inova Health outside of Washington, D.C. So, Anna, welcome.
Thank you, Steve. A true pleasure to be with friends.
Yes. And both, anyone who's listened to this podcast, I'm sure, is familiar with both Susan and Anna, so it's a pleasure to have both of you here today. We're also super thankful to be joined on this episode by a courageous cancer survivor and a great cancer patient advocate, Julia Maués, who has agreed to talk with us about her experiences as a patient and as a survivor, and really as a very productive patient advocate as well. So, Julia, we really appreciate you joining us today. We especially appreciate your courage in being willing to share some personal insights into your experiences. So, welcome.
Thank you. Thank you. It's wonderful to be here.
And I'm going to turn it over to Susan and Anna for some discussion about Julia's experience.
Great. Thank you, Stephen, for this kind introduction. And thank you, Julia, for joining us today on this podcast. Thought that we would just start out about learning a little bit about you first, and maybe you could just tell us a little bit about yourself and your life and sort of your experiences before you had to face a diagnosis of breast cancer.
Thank you. Yes, I'm originally from Brazil. I moved to the U.S. for college and was busy with my career as an economist when I was diagnosed with breast cancer at 29. My career was as far as possible from cancer, and I was thrown into this world really through my own diagnosis.
And can you tell us a little bit, Julia, about, I think there were some complicating factors around the time of your diagnosis of breast cancer. Is that correct?
Yeah.
Were you at that time?
Yes. Numerous complications. I think that the first thing is that I was pregnant at the time. So I was pregnant and I found a lump in my breast and showed it to my OB, who took it very seriously and observed it for maybe a few weeks until she said, let's have this imaged. And an ultrasound became a biopsy, and that turned into a diagnosis of HER2-positive breast cancer.
So obviously dealing with a breast cancer diagnosis at any age is difficult, but you also had the issue that you're dealing, with your pregnancy and potential complications with that. Can you just explain a little bit about what your treatment was like, what it looked like as you were dealing with that initially, your initial treatment?
Yeah. It was very surprising and hard to accept that the standard of care for a woman that's pregnant and gets diagnosed with breast cancer is chemotherapy. I remember my first reaction was that I wanted this cut out of me, right? I wanted surgery, and I thought that would be the least harm for my baby. But through a lot of counseling and wonderful doctors that explained the science to me, I was convinced that it was safe and that the best for me and for my baby was to receive adriamycin and Cytoxan during the pregnancy. And then after the delivery, to switch to HER2 treatment.
And how did that go for you? Tell us, like, in terms of, a healthy baby, and what were the outcomes from that treatment for you?
Yeah, so I had 4 cycles of this chemotherapy that we cancer patients know as the red devil. It's very toxic, but it's also older, and there's data on pregnancy, and we know that it is safe for the baby. So I received 4 cycles and worked very closely with a high-risk OB team that would monitor me very closely. And I went to the labor and delivery a few times just to be monitored and after the infusion. And then at 37 weeks, I was induced and had my son. I was obviously bald from all the adriamycin, and he had all this hair when he was born. So that is just a very special memory, because it was proof for me that the placenta had done its job of filtering the chemo, and he was shielded from that in some way. And
Oh.
so yeah, he was perfect. He was born. We went home after a couple of days. When we were still in the hospital, I did scans that I couldn't do while pregnant, and unfortunately, we discovered that the cancer was not only in my breast, but had spread to other parts of my body.
Oh, that must have been so difficult. Well, I'm very happy to hear about what you said about, your son was born with hair, and that's such a special memory. And as you alluded to, the placenta was protecting, your son through that. But just tell us a little bit about that. That must have been so challenging because, as you noted, you couldn't go through these scans when you were pregnant. You had them after your pregnancy, and you had already been on therapy at that point, right? You'd had this 4 cycles of the AC, and you'd had, I guess at that point you had not had any of the HER2 targeted therapy because they were waiting for your son to be born, right?
Yes, that's right. I did, however, have a pretty good response to the adriamycin. They could tell from the breast mass that it had shrunk significantly. But in this scan, they also could see that the cancer had spread to my bones, and later we discovered also my brain, and yeah, those were really, really hard days. I had a newborn baby and this diagnosis of a disease that was going to kill me. And I remember having this fear that he would become too attached to me because I didn't think I'd be around for long.
And how long ago was that, Julia? Do you mind sharing that with us, how long ago it was?
Yeah, so that baby will be 12 years old this summer.
That's amazing. That is so amazing. Wow. So as you were dealing with all this, and I'm sure they were talking to you about different therapy and more therapy, HER2 target therapy, at what point did you feel that there might be some issues with regards to your cardiovascular health?
I had so just the risk to my heart was something that was discussed a few times because of the therapies that I had to be on. But until it was a problem, I had this idea that this is something that can happen, but it most likely would happen to someone that is not very healthy in other sense. And I was healthy and I did not have any heart problems until that point. So we all really didn't think it was going to happen to me until I had a routine echo. So with this treatment that I was on, it I had to have echoes on a regular basis to check on my heart, and a routine echo showed that my ejection fraction had dropped significantly. And at first, I didn't have any symptoms to tell me.
You bring up a good point, Julia, because you were being treated with HER2 targeted treatment. You'd had 4 cycles of the Red Devil, as you said. And while we have very good guidelines and guidance around cardiac monitoring for people with early stage breast cancer that we're treating, once the cancer is spread and it's metastatic, those individuals are offered numerous types of HER2 targeted therapy, but the guidelines are very unclear as to how often, we should be doing things such as echoes. And as you alluded to, you were young, pretty healthy otherwise, and not expected to have cardiac problems. So at the time, you're saying that you had a routine echocardiogram and they picked this up. So how often, were you having echocardiograms when you were going through this treatment?
I think it was every 3 months that I was having them. I can say that even to this day, my my nurses in the infusion clinic are really the ones that stay on top of the echoes, because like when I arrived to the infusion, they say, when was I'm not seeing your last echo. And my doctor is in a different facility. So I go into that my chart and send them that echo, but they almost don't want to give me the chemo if I don't have a recent echo showing that my heart's okay.
So can you maybe just describe a little bit of your experience about what happened when you had that echocardiogram done that showed your ejection fraction had fallen? And I can't remember if you told us, how low did it go?
So the first echo was showing 25. I believe it was 25, and it was a huge drop, and everyone was very concerned, and I stopped the HER2 treatment at that point. And I really thought that was the beginning of the end of my life, because I had cancer everywhere, and now the treatment that was supposed to work couldn't be given anymore. And this like very, very important organ was getting very hurt by the treatment that I had to take. So I actually moved to Miami, and this was possibly going to be the end of my life. It was like a just really hard time, and my cardiac health kept deteriorating. I started having symptoms. Eventually, I was in the ICU in Miami, and my ejection fraction dropped as low as 10.
Oh, my goodness.
Yeah, and I was very fortunate to have really excellent care there. I think it couldn't have been any better than my breast oncologist was married to my cardiologist.
Well, that helps. That's really amazing. So, Julie, at what point did they sort of reach out to cardiology to sort of try and help with this, because as you pointed out, you were on therapy that's keeping, your cancer, from spreading more, and that's such a vital, important part of your life. And then your heart was, damaged. And so you wanted to continue the HER2 target therapy, but you couldn't when your heart function was that bad. So it's really, it just speaks to the issue of really working together with our colleagues to try and ensure that we keep all of you healthy so that you can keep, your treatment going. But just interested in what that interaction was with the cardiologist you met when you were in Miami and your heart function was that poor.
Yeah, so I used to live in St. Louis, and I was treated at WashU, and that is where the first echo showed a decrease in my ejection fraction. And I think I probably did see a cardiologist there at that point. But what happened at that point was that me and my family, we told my oncologist, we're thinking we have this crazy idea of moving to Miami if this is going to be the end of my life. What do you think? And he said, I think it is a crazy idea, but I think it is a good idea. And then his mentor is the breast oncologist that cared for me. And so he said, my mentor is in Miami, and he happens to be married to a cardiologist. So I think this is a good fit.
So then how long were you in Miami for?
I think between like November and March, because it was really the winter that I didn't want to spend in the Midwest. And eventually my ex-husband's job he needed to come back for that. But we spent a few months in Miami, and I had some time in the hospital, and the cardiologist really started medicating me and getting my heart healthier and more protected, until it was good enough where they could restart cancer treatment, but they wouldn't do HER2 treatment. So I went back on cancer treatment, but it was just weekly Taxol.
So and how long, I mean, that's really important thing to note too, because so many of our HER2 targeted therapies now are these antibody drug conjugates where they're linked. It's all linked to a HER2 agent, and we're giving less chemotherapy. So it really is important to be, proactive about looking after one's heart health when you're going through this treatment, this life-sustaining treatment. We have the pleasure of having, Dr. Anna Barac on the line too, and I know she has been an integral part of keeping your heart healthy as you, continue to receive ongoing treatment. So can you tell me a little bit about your interaction with Dr. Barac and how that became part of your treatment and how that worked into your importance of being able to continue your cancer care?
Yeah, so I moved to DC for personal reasons, and spoke with my team in St. Louis and asked them, who should I see for medical oncology? Is there a cardiologist that I should see? And my cardiologist in St. Louis, Dr. Doug Mann, he said, you are just so lucky that the best person possible happens to be at the hospital where your medical oncologist is, and she specializes in cardio-oncology, and you couldn't get better care than with her. That was 2016, I think, when I started seeing Dr. Barac.
That's lovely. The long relationship. That's great.
Yeah.
So I'm going to ask Dr. Barac to comment just briefly. So Dr. Barac, hearing and Julia very well, can you just sort of comment on some of the things that she's experienced in terms of, trying on lifelong therapy essentially, but, experiencing significant cardiovascular dysfunction related to that therapy? And can we do a better job at trying to avoid these? Because, Julie, you had to stop your treatment, particularly the HER2 part, for a while because of your heart function. Is there something we can do to keep one's heart healthy, or so that doesn't happen moving forward as women are facing this diagnosis?
Well, I will first say that all of us as physicians, I feel, and I personally stay humble and always inspired by patients like Julia that really feel she taught us all. And this example that she just shared was, I believe, permissive toxicity before we called it permissive toxicity. So we all know that the drugs were first. The reason why, there's so many elements from Julia's story that resonate, and I would highlight the things that were all done right. I actually am not certain that there could have been anything else that could have been done better. And it's just an example of thinking if those things were not in place, I don't think that we would be having good outcome. So she had a rare cancer at her age. Breast cancer is the most common cancer in women, but not during pregnancy and at young age. And of all women who are diagnosed with that cancer at that time, very few, this is your area, Dr. Dent, but thinking of very rarely are there metastatic upfront, sort of the prognosis is terrible. And then the incidence of the complication that Julia had is extremely low. I think right now we've had so many studies where we actually watch patients, and I would say that less than 2% of patients who receive anthracycline followed by HER2 targeted therapy would have that dramatic decrease in cardiac function. But that is exactly what was seen in early studies, and that's why the echoes are there. And you could say, she was a young woman with no risk factors. Why would we even follow? But she was followed by echocardiograms, and that was seen. So I think that was really a victory in a way, because it was recognized. Of course, the immediate next question is what happens with cancer therapy? And you would say, I always ask myself as you just learned, I learned of Julia's story in retrospect, right? Like when she was already out of the gray zone, when I think that the first echocardiogram we got was in the range of high 40s LVEF. I was like, oh, this is easy. We've seen much worse. So what I'm saying, I wonder what the circumstances, could there be a contribution of peripartum? That's an area where cardiomyopathy, and that's an area that I don't know we will ever have clinical trial evidence. This is going to stay in case series, because and I believe that in looking into records, everything she was in the ICU, hemodynamically unstable. That was not the moment to start the HER2 targeted therapy. But as soon as she could, I think I remember, and Julia was first in many, right? Like in many things that we today do routinely. For example, today we routinely start patients on Entresto, such as sacubitril valsartan with cardiac dysfunction. I believe that when she first came, we were like, oh, tiny dose, like blood pressure was really low. So we worked from lisinopril into ARB and to Entresto now. So that I was, in a way, I was fortunate that I could work on the good work. And again, I think she was in the environment where there might have not been a dedicated cardio-oncology program, but a lot of cardio-oncology program is good practices of oncologists. She knew oncologists that had to continue, and the cardiologists to say, okay, get me there. So I really think that, and Julia's questions, so this is now fast forward. I think early on, I'm not sure that even if this was everything happening today, I would think only in thinking of other patients, how can we make sure that everybody has the same experience? Would they have this? And, I'm not sure I believe in luck. It's more serendipity, right? Things sometimes happen for a reason. I feel that a lot of things Julia has spent ever since I met her, all the work she's done through the patient advocacy groups and the works through FDA on making sure that all patients, if they were in a similar situation, hopefully not as severe, not that life-threatening, know what to ask for and teach us all as providers on how to work. So again, I think everything was done in really right way. And in some ways, she's championed the way. Like when I first met her, I was like, I think we should start. And I have to say that Dr. Doug Mann is the editor-in-chief of JACC, Basic Sciences for Cardio-Oncology, for JACC Basic Sciences. And it was the biggest compliment in my life that I could get, that he could share a patient like Julia. So that's a personal thank you.
Great, thank you. And I agree. Jill, you were very fortunate to have those echoes done, going through your treatment. That's not how everyone practices. I mean, some oncologists will just not do that many echoes. And I think there's a lot of variety, and it would be, I think moving forward, what I would like to see is there be some consistency in how we approach heart health, particularly in individuals with metastatic disease who are on lifelong therapy. So, but one thing I wanted to ask you just a couple more questions about your thoughts about the value of oncologists, working together with cardiologists, the whole field of cardio-oncology. I mean, as Dr. Barac said, it's good care, it's good oncology care, it's good cardiology care. But as you know, those two different disciplines can often work in isolation. So maybe just from your perspective, how did cardio-oncology and that idea of the working together really impact your life?
Yeah, so I think cancer patients, and especially metastatic patients who live a long life on all this therapy, they have all these other health problems, right? They still are living their own lives, and they're getting older, and things are happening, and it's often really hard to interact with non-oncologists because they often get really scared of our diagnosis and of doing something that could harm us. But I will say that in my case, the cardiologists all have been part of the cancer care. It's almost like they weren't external, they were part of the cancer care. I mean, I have so many memories of seeing my oncologist and asking her something about my heart, and she said, "Let me text her." And she will pull out her phone and text my cardiologist right away. So, yeah, like their connection is not like parallel, it's like part of the same team, and I think this has played a big role for me. And I have been very unlucky with all these diagnoses happening, but I have also been very lucky with the care that I've received. But I will say that in addition to luck, there's a good amount of privilege there. I have received care at some of the amazing comprehensive cancer centers in the United States. I have excellent insurance. I guess being such a complicated case often gets me the top people to work on me, and yeah, I've been very fortunate to see the level of care that I have seen.
Well, Julie, I mean, you've also been a very much of a patient advocate and really focused on educating others, including providers. You have some initiatives of your own that I was hoping you could share with us. Could you tell us a little bit about GRASP and when and how the idea was formed and what kind of initiatives and programs you've developed?
Yeah, so my cancer diagnosis was in 2013, and I was very sick for a while, and then I think it was not until 2016 or so that I kind of entered the world of meeting other patients and slowly participated in trainings and kept meeting people, and this is started giving me some meaning and like a purpose for my own experience and a way to make something good out of my own very tragic experience. And I met a few wonderful patient advocates that have also had this desire to turn their own experience into something good. And one of them, Christine Hodgson, who is also a young woman living with metastatic breast cancer, and we became very close, and we both really enjoy the interaction with scientists. And we realized that it is not something that happens naturally, and that these connections need to be facilitated more often. And so we created GRASP, which stands for Guiding Researchers and Advocates to Scientific Partnerships. And we have a few programs at scientific conferences that bring together scientists and patients to discuss posters. And we also have like one-off virtual discussions between scientists and patients. People might want to discuss with patients a project before they apply for a grant, or when they're starting to have an idea and they want that scientific idea to also connect with the real experience of people living with that disease.
That's so wonderful. And I think, congratulations, by the way, on, not only, are you living with your disease, you're raising, your son, and I see you all over speaking at meetings, wherever possible, trying to sort of help other individuals who are facing similar circumstances and educating everyone, not only individuals with cancer, but educating healthcare professionals about how we can improve patient care. So, just in the closing moments, do you have anything that you would like to sort of say to oncologists, other healthcare providers on what can we do to try and improve upon, patient care? We know, as oncologists, I can say we know the science in terms of, the next phase 3 study and which treatment might be the best. But as we know, treatment is much more than just the cancer therapy that we deliver. So any sort of final words of wisdom, I would say, for my colleagues?
I think for me, the wonderful oncologists that cared for me, they have always been focused on me as a patient, and they carry that toolbox with treatments and options to care for my cancer. But really, the focus is my well-being, and this means different things for different people. So for someone that has a job that requires them to be outstanding in construction, they might not be able to be on a drug that gives them a lot of diarrhea. And even though that is the drug that has won the last phase 3 clinical trial, that might not be the best fit for that patient. And I think incentivizing these discussions to happen around each individual situation and each individual patient, I think that's very important.
I think so too. It's really treating the whole individual, and I think understanding what's meaningful for them, and sort of what their needs are, beyond, as you said, that may be the best drug, but maybe not in that particular person for a variety of reasons. Dr. Barac, do you have any sort of closing comments around, working with our colleagues? We are both, very invested in cardio-oncology and bringing these two disciplines together, but any sort of parting words of wisdoms for our colleagues?
Yeah, I'm truly grateful to Julia and to patients like her who teach us all in different ways. I think that is a lot what about care is and the largest impact of care, particular initiatives that Julia has spearheaded through GRASP, but also through FDA, working with regulatory bodies. So many things goes into care, and so many things go into assuring that overall, both cardiovascular and oncology outcomes are the ones that need to be met. So it's really, it inspires us in thinking of how do we gather evidence when sometimes might be hard to find evidence for, that particular patient. But I feel that's a true success. So, and then thanks to you and Steve for bringing this to our audiences.
Well, thank you both. And I always like to think of it as, in the past, I think we're sort of brought up in our training, looking at the disease and the disease-centric approach. And I think we need to focus on the person-centric approach. And it's really marrying that the therapies that are available to that person. And importantly, working with our colleagues, like you said, Julia, picking up the phone, texting, emailing, so that we're working together to come up with the best therapy and actually trying to essentially work together to allow individuals to benefit from the advances that we've made in cancer therapy, because a therapy is not of any value if you can't receive it. So I think with that, I'm going to close this podcast, and thank you so much for joining us. Thank you, Julie, for sharing your personal experiences. You were a true inspiration, I think, to all of us who work in this field. Thank you, Dr. Barac, for taking such good care of Julia, and we're wishing her many, many years of a fruitful life and your family as well. So thank you for joining us, and thank you, Stephen Casale, for this podcast today.
Thank you for joining us on this episode of Heart to Heart. And if you would like more information about any of the ICOS resources or opportunities, go to ic-os.org. That's ic-os.org for more information.
Free audio post-production by alphonic.com.